With the fourth speaker today, Wendy Carroll. Wendy's the former general manager of new business and stakeholder relations at Healthdirect Australia. She's got over 13 years of experience in commercialization, innovation leadership roles across digital health, pharma, biotech, medical device sectors. Prior to working with Healthdirect Australia, she worked with Sanofi, a pharma company, worked in partnership, in licensing, and collaboration. Wendy has some ideas today to talk about failure to scale. Please welcome Wendy.
Well, thank you very much for your time and attention this afternoon. I think the inspiration for this talk today was very much around, why deployments of IoT in health that might enable new models of care, virtual care, have failed to deliver complete scale. There's been no shortage of pilots in health, and particularly in the Australian landscape, but that ability to deliver new models of care that improve efficiencies, reduce costs, and deliver better health outcomes just hasn't seemed to have we haven't seemed to have nailed it and gotten there. So today's discussion is just a brief overview of some of those factors that have contributed to that. And I guess as you think about entering the health space, or if you're in the health space, these might be points that you'd want to consider when you're designing and developing your deployments as well. Oops. Forward. Okay, so I guess one really important part of the health ecosystem that really can't be underestimated is the cultural inertia around failure. Okay, so when you use the word fail in health, it conjures up a completely different meaning to perhaps what it might in other industries, right? Failure means a loss of life. Failure means something catastrophic has happened. So it's hardwired into the health system and the culture around this risk aversion and this lack of willingness to try new things that aren't proven, tested, and have a lot of data behind them. So that I guess that spirit of entrepreneurialism where we talk about failing fast and thinking fast and all that sort of thing, we've got to be very careful in health that we don't scare the horses, so to speak, when we do that. Health is very complex, right? It's human. It's got a human dimension. Here, you've got a gentleman presumably at the end of his life, and all that matters in that moment to those people are every breath and reminiscing on a lifetime of experience. But there are many lenses with which you can view that experience as well. Okay, so to that family, there's one lens. To the bureaucrat, there's the cost of keeping people alive, and it's something like 90% of your health spend, or the money that is spent on your health, is incurred in the last 2 years of life. So that idea that we're all aging, we're all getting sort of sicker and living longer is a real issue for the government and policymakers, and that's a lens you've got to consider if you're looking to play in this space as well. And scale really matters because health is complex and the issues around health are really, really, really complicated as well. So if you consider that health today in the Australian environment is touching on 10% of our GDP, 1/4 of all tax revenues collected is spent on delivering health services by the government, and the fastest growing segment of health spend is actually the spend that we're all making as consumers out of pocket towards our own health and well-being. And when we start to realise that in a more omnipresent way, our expectations around health, and they're already quite high, we have a really great health system by world standards, but our expectations of what we want from health, and as we age, are going to increase when we're paying more for it, not decrease. So, for those of you who have private health insurance, you're damn well going to use it every year because it's so expensive. Your expectation around seeing the top oncologist, if you're ever, God forbid, in that situation, or having the best of care in other realms when you're having a child or otherwise, is there. So that's, that inertia around expectation is something, again, we have to consider. And then there's some really big sort of, I guess, macro factors at play here. We talked about aging briefly, but the epidemic of obesity. 63% of adults are either obese or overweight. And just yesterday, there was a statistic released, and Jacob talked about that earlier, around there are going to be more obese children in the world by 2022 than there are underweight and undernourished children. And that's terribly frightening, and the terribly sad part about that is it's completely preventable. Obesity is a known contributor to a whole bunch of other chronic diseases like diabetes, arthritis, and even depression. And so we really have to sort of look at that as a macro issue that we need to deal with. Over half the population has one or more chronic conditions, and I think it reaches something like 25% of people have 2 or more. Now, once you're over 85, that number is about 90% of people. And again, that's when you start incurring a lot of costs, and that's when your experience of health starts to get very complicated as a consumer, because you're being treated for multiple conditions, and our expectation of that one-to-one care means that you're going to see an endocrinologist if you have diabetes, you're going to see a dietitian if you've got diabetes, you're also probably going to be seeing an orthopedic surgeon to get your knee replaced, you're going to have upper GI issues, and probably your gallbladder is going to be removed at some stage, and. So your journey through life and through health or lack of is going to be very complicated. Preventable hospitalizations, again, we've all know with the flu epidemic this winter, we've had it brought home to us how much it costs to have a hospital system come to its knees. And 40% of hospitalizations are preventable as a result of these chronic disease or the prevalence of these chronic diseases. So we need solutions that deliver impact at scale to solve these problems, because otherwise we're going to find, come flu season or come 20 years' time when we're much older and sicker, that our hospitals are completely chocked up with people living with chronic diseases, and things like cancer treatments and other surgical procedures, etc., just never see the light of day because the money's run out treating these other things. Okay, and I guess the other part of health, which is really complex, adds to the complexity, is although we focus a lot about the health system, the hospital environment, the interaction with medical professionals, 99% of your life is spent away from the health system, generally speaking. And the decisions you make when you think about things like obesity and chronic conditions, a lot of the time the decisions you make in your 20s and 30s or younger has a real impact on your health further down the track. But those decisions are influenced by your, socioeconomic status, your education, where you live in proximity to where you work, etc. So health, again, I reiterate, it's complex, and the solutions aren't necessarily just in the domain of health. They're in the community, they're about influencing the people that care for us, they're about influencing the broader ecosystem within which we live as humans. And as technologists, it's really easy to forget that and get seduced by what the technology can do. So we need to rethink how we solve problems. We need to rethink about how we involve ourselves in problem solving and who we involve as well. It's not, to tackle these big issues, it's not good enough just to say, well, I've had a patient focus group or a person focus group, and I've developed this new fitness module and it's going to solve the obesity epidemic. If we forget the interconnectivity between who we're trying to solve the problem for, the role of the medical professional, the role of the broader health ecosystem, we potentially are missing an opportunity. So I guess rethinking about how we solve the problem and how we execute those solutions is really critical. So here in comes the Internet of Things. And in health, we've already heard so many great stories today about what the ecosystem of IoT in health looks like. You've got from the simple wearables and the fitness trackers and so forth, all the way through to sensors in the home monitoring systems, sensors that can detect, all sorts of manners of biometric data and feed back into some sort of remote platform that's either monitored at a hospital or a remote monitoring centre, and then being able to deploy instructions to your care team or yourself as such. So today we're really, if you think about the days of the Earth being flat or the Earth being round, we're kind of at the stage where the Earth is still flat in a lot of ways with respect to IoT in health. We're able to track our steps, we're able to track activity, we're able to monitor our blood glucose levels, our blood pressure, and some basic biometric things in the home. We're able to connect with other people that are like-minded, or perhaps our care team, our clinicians, and we're able to educate each other in the process of doing so. The future is all about how do we aggregate and collate all this data that we're generating to enable predictive analytics, and therefore target and personalise interventions towards perhaps behavioural change initiatives or otherwise. How do we, personalise the deployments as well? And that's a huge a hugely important aspect, because by personalising, as you know, you become more engaged in the solution and utilising it. And health, like many other domains, you know, there's a saying, I guess, in the pharmaceutical space, you have 100% ineffectiveness if you don't take your medication. It's the same with these interventions. If you don't participate in using your fitness tracker or your Strava or whatever it is, you're not going to get the benefit from it. So engagement is really important. And again, a lot of the technology to date hasn't really nailed that piece in the long term. It might, you know, have a 3-6 month benefit, but not something that is lifelong and life-changing. And that's what we need to crack if we're going to crack these big problems. And then, of course, data prevention, it goes hand in hand as well. So we're a long way from that vision of what IoT could deliver in health, and part of that, as we've discussed and seen in many presentations today, is around the data layer, the issues around and the interconnectivity between security, privacy, and how the data flows, and who owns it and where does it flow to. And I guess it's a subject of ongoing and it will be never-ending debate, because it is really personal. Who wants their HIV status recorded on a public health record, for example? You know, these are the questions we have to grapple with as a society if we're going to realise the benefit of IoT in health. Oops. Okay, so I've kind of just tried to distill the challenges and the failure points, if I can put it that way, in deployments into a few key themes. And I guess I summarise it by saying, firstly, you know, a failure to completely and utterly understand the consumer, the end user of your product, and B, or the solution, and B, a failure to completely understand how that interplays in terms of that whole health ecosystem. And it's complicated. And for example, a lot of the time in health, the end user of the solution is not the person that's paying for it, or it's not the person that may be benefiting from having access to data and information. So that in itself is very unique to health and very different to a lot of, you know, if you think about ag tech or otherwise. So that's something that, again, is a trap to fall into, and it's something that needs to be considered heavily. I guess probably the number one reason I think that deployments do fail, on top of anything else, is a failure to really have a clear idea of how you're going to monetize the solution and how those fundings streams are going to really work in reality. So people might have an idea of how to monetize it, and I can probably have a list this long of companies that I hear about or come and pitch and say, we're going to collect all this data and we're going to monetize it, we're going to sell it, we're going to put advertising up, or whatever it is. And that is a strategy, yes, but unless you've performed experiments and tested that will work and will engender trust and so on, that's going to be a very fraught strategy. Bear with me. The other part is really failing to understand the technology layer in health, and that in itself is really complicated, and I'll dive into that a little bit more in a moment. But or it might come from a sense of completely understanding the technology but failing to understand the complexity of how people interact with the technology in the health system. And this is often the case if companies from overseas are trying to pull a model that works in another market, say Germany or something similar to Australia, and they're not realising that how fundings flow. Okay, and then, yeah, so I'll just quickly, I've been given the signal on timing, so I'm just going to keep pushing through. I guess, so when it comes back to one of the failure points in terms of understanding that locus of control around the person being the centre of their care, we can't ignore that there are other people in that person's ecosystem that influence how they interact with the technology, whether they use the technology, and how it's deployed. So that's that consideration. And I guess the other part around deployments is, you know, the iPhone, the smartphone today is ubiquitous with people's lives. People don't leave the home without it. And I think Andrew highlighted the statistics around screen time and utilisation. So deployments need to utilise as much as possible what already exists in the community, rather than having to rely on having to distribute new technology componentry. There's also this notion that there is no standard health journey, which again is really, really clear in health and really difficult to get your head around. And it comes back to the whole experience of health and the experience of not unwellness, if I can put it that way. Once you have multiple different chronic conditions happening, and we know that that's half the population, there is no one standard consumer journey. So, you know, if you're building products and deployments that are based on a linear process that that look at health in that way, they're not likely to hit the mark and the engagement factor, wow factor with that person. The monetisation piece, and I've deliberately included this slide, it's come from a parliamentary report on health funding, and it's not because I'm really hopeless at PowerPoint and I can't design slides. This is a really ugly slide, and it hasn't changed in 13 or 14 years. This was from 2004, and it shows the complexity of how funding for health flows in the Australian ecosystem. Okay, so if you don't really understand that and understand how it truly works, and you think you've nailed a monetisation strategy, we know what the outcome's going to be, or likely to be. Okay. And then the technology layer again, I brushed on this earlier, and we can certainly talk about this. I'm happy to discuss this offline or in the panel section, but it is complicated, and some of the assumptions you would make from other industry verticals about what exists in health and what sort of tech layers and level of cloud engagement, etc., your assumptions can be very out of whack. So again, understanding that ecosystem and understanding how your deployment will fit in with that is really important. And again, I raise, quick and simple example, medication adherence, an app for patients to help track their medications usage. And someone's got 3 or 4 conditions and 7 or 8 medications, that becomes really important. And a novice developer will say, well, it would be really good if we could tell the patient's GP if they haven't taken their dose. Now, did anyone stop and think, did I want to ask the GP if they want to receive that information? Okay, who does want to receive that information? And if they did, what would they do with it? And what duty of care does that raise? And what sort of implications and privacy pieces down the track that would raise? And B, how would you even get that data to them securely? Et cetera, et cetera. And that problem is compounded 10 times over if you consider moving radiology results or imaging results that you've had performed at Royal North Shore Hospital and you happen to be being treated over in Nepean or in a private hospital later on. So they're the issues. The My Health Record, which some of you may have heard of, is the government's attempt at centralising our personal health data. It's a personally controlled health record that we each own our own data, and that is a step forward in terms of having this package of information about ourselves and our own health being able to be transported with us throughout life digitally. And probably the last point, without over-labouring it, because I am getting the wind up on time here, is that overcoming that cultural inertia around risk aversion is really critical. And again, the conversations around the opportunity with AI and machine-to-machine learning or robots performing surgery, all that sort of thing has to be, there has to be a change program around this, in the same way you would have a change program if you were implementing an accounting system in a big corporation or otherwise. Now, if you think about New South Wales Health, for example, it's 120,000 employees. Okay, that's the same size, with a operating budget in the billions. That's the same size as a multinational. Now, you wouldn't dream of launching, a new ERP system in Pfizer, for example, without doing a lot of work on the change management side and planning it and hiring the right talent to do that. Yet in health, that's exactly what we do. We go in, we talk to some technology guys, we get, this is a great idea, and forget to engage clinically, or vice versa. We engage with all the clinicians, but we fail to engage the technology teams. And again, there's so many opportunities for breakdown and failure if that's how we do it, if that's how we plan it. We're actually planning to fail. So overcoming that cultural inertia really takes good project governance, everything that sounds really non-agile right now, but really, really concerted effort to map out who the right stakeholders are, who should be in that delivery team, and working through a very clear change program around the deployment to make it work, make sure it works. And I guess my last point on this is, if you're planning to use a pilot to generate the evidence to prove your concept and so on, and your thinking hasn't extended beyond the pilot, i.e., what if we do prove it works really awesomely, then you're also going to be facing a road of a very, essentially extending your timeline to execute and deliver on the goals of the program. So there's that. And then the last part is Trust, okay? Building trust. Once you start to play in the space where you're potentially collecting and utilising health data, that ability to be transparent and clear around what you're doing and how that information is going to flow through the system is going to be critical, because again, that is a point of potential failure in the process. You could receive a whole bunch of unwanted, I think we heard about it with Amazon, how will that look on the front page of the paper? The criticism and you've got to be willing to withstand that and answer to it in your deployment. So that trust piece is really critical, and obviously, I don't need to talk about cyber because we've heard such wonderful discussions on it, but building in the cyber and the security piece up front is, it's a mandatory, it's cost of entry. If you're not doing that, don't bother. And I'll skip over that. So that in a nutshell is a really brief overview of some of the opportunities, I guess, some of the failure points, but therefore the opportunities to enable deployments to happen at scale. I'm very happy to take questions in the panel to run through that in any more detail. So thank you for your time.